floor is yours.
Well, thank you. Thank you so much for that nice introduction. Now, one little correction, I'm not an anesthesiologist. I'm just a PhD, not a real doctor, as my kids always tell me. But I've been working alongside anesthesiologists for a long time. I am from the University of Utah, where we have right now beautiful fall colors. We're expecting snow on the mountains any day now. Before I start, I have disclosures. I am involved with 2 startup monitoring companies out here in KSQ, just so you know. And yes, we're going to be talking about anesthesia patient monitoring in the future. We're going to try to predict the future. And as we all know, prediction is difficult, especially as it concerns the future. And so what I'm trying to offer here today is just a few different ways of thinking about where patient monitoring anesthesia might be going to. And one approach for doing that might be to go back to where it all started and then see how we got from there to here where we are today. And interestingly enough, this of course is the first publicly recorded case of anesthesia, 1846 MGH, and it turns out on that very first day there was already patient monitoring. Because Dr. Morton here holding the vaporizer actually did have an assistant, a patient monitor, who held a finger on the pulse and used visual recognition to look at the face and looked at probably the chest movement, all very qualitative of course, but the first patient monitoring. And it started from there, and then patient monitoring really took off. I'm not going to go into all the details, just to say a little bit about how it started on mechanical, and then when the inflammable, volatile anesthetics came on the market, we could introduce electronics. Then it, of course, with computers, it was computerized, and then so it went on and on. And I can detect 4 different trends at a minimum that we can try to extrapolate where, and we can see where things may be heading to. And the first one is that we started non-invasive, if you think about blood pressure, became invasive with arterial blood pressure and cannulation, and now we're seeing more and more non-invasive blood pressure. And the question is, where does that go to? What's the extrapolation for that? And it could be that we're now going actually into non-invasive but non-obtrusive, right? Things like these buttons, that bio buttons that Medtronic is distributing, or the Cybele that is Draeger partnering with. And they can do basic vital signs, EKG, heart rate, respiratory rate, all without wires, wireless. The question is this good enough for the operating room or the ICU? I think they probably still have a way to go, and it's certainly something that works really well on the general ward, where it is important to monitor, because right now we're only monitoring about every 4 hours or so. Even less obtrusive, of course, are camera-based systems. Here on the left, you can see a system that Paul Addison has published about. He is part of a research group of Medtronic in Edinburgh. And then on the right side is a concept drawing from the company that I'm advising out of here, where we have shown that we can do respiratory rate by camera, we can do heart rate, pulse oximetry. We just published a paper in anesthesiology where we showed we can do pain and also measuring falling out of bed risk. And the cool thing with these camera-based monitors, of course, is if you have a new parameter, you don't need new hardware, you just need a new and better algorithm. A second trend is, it started with on-demand, right? You had to manually inflate the blood pressure cuff, and then it became automated. If you remember 1970s, the Dynamap. Then we have continuous, and then the question is, where does this go? And I'd say, hey, maybe we're going to go into predictive, right? And just for 2 things that are on the market already, this is the oxygen reserve index that Massimo is putting out. We can see here's a precipitous drop in SpO2, and with their oxygen reserve index, they can actually already see that the drop had started much earlier, and so you get a forewarning maybe 4 or 5 minutes earlier. And their idea was actually that the venous oxygen saturation can be proportional to the arterial oxygen concentration, as long as certain assumptions are held constant. Similarly, Edwards and LBD put out this hypertension index developed by Joe Settlers in Amsterdam, and where they can show maybe 4 or 5 minutes before the blood pressure on the bottom here is going into a hypertension intensive period, they can show even earlier that may be a risk. The third trend, the third trend is something where it started out qualitative, right, the finger on the pulse, then we go into quantitative, and then I was thinking about how does that extrapolate? And the key with these measurements is that they were systemic, right? And I think the extrapolation of that is something that we still don't really have much, and that is we need to monitor regional or end-organ type signs. And of course we have this to some degree with cerebral oximetry, or we have the ST segment detection that looks at cardiac ischemia, but we don't have this for other organs. And this is not unimportant, right? Because here is a study that our friends in Melbourne, Roger Evans and his colleagues did, where they showed in sheep, if you give norepinephrine, yes, the blood pressure is going up as expected, and the cardiac output is going up as expected, but these are systemic measures, right? Does that mean that the end organs are doing well? Not necessarily, because, for example, the tissue oxygenation in the kidney actually went down during those periods. So it would be nice to know this, to know how the kidney is doing, for example. My colleagues and I, we have developed a urinary oxygen sensor that we have tried out in cardiac surgery, where it turns out that kidney tissue oxygen, low kidney tissue oxygen, is a precursor common pathway for acute kidney injury that happens quite often, about a third of the time in these cardiac surgery patients, and it's really, really not good. It doubles and triples the mortality risk, and it doubles the length of hospital stay. And we were able to show that in about 90 patients, we were able to show that we could actually detect the risk of AKI already in the operating room right after they came off bypass, where the traditional methods based on creatinine or urine output became only diagnostic maybe 2 or 3 days post-operatively. So that's a good start, but of course there are other opportunities. As I said, we're pretty good in monitoring the brain, the heart. We've heard a lot about the lung today, but we're working on the kidneys, but how about the liver, how about the intestines, how about other organs? Another fourth trend is that monitoring in anesthesia really followed where anesthesia is going, right? We started in the OR, but now more and more we have non-OR anesthesia locations, and monitoring will have to move with that. And for example, as we get more into directed and supervised care, oversight care, we need to create monitoring and displays that allow that to happen. As anesthesia is going out into the surgical home, into prehab and rehab kind of positions, we need to think about where monitoring can support that better. And I will get into that top point in a minute. And then finally, there's a lot of ongoing opportunities, and I'm just mentioning them briefly. They are ongoing because we have been working on those for a long time. And there's still opportunities because we still haven't really solved them. For example, the alarm off button is often still a very much used button, right? Why is that? Why aren't our alarms context aware? Why do we still have annoyance alarms? Why are we not alerting on trends? And we also could work on better alarm enunciation, maybe improve the sound design, maybe announce it by the voice. We're seeing this in aviation, for example, right? Or deliver it directly into the ear with all of us wearing these AirPods all the time. These are all points, by the way, that of course we've been working on that forever. I did my PhD back in the days when the dinosaurs roamed around on smart alarms. So I think academically, we have kind of sort of solved that issue. We now just need to get it to the bedside. Another ongoing opportunity is something that I always like to introduce with this diagram here. This is from David Gaba. He publishes in his book Crisis Resource Management and Anesthesia. And to me, this is amazing because this shows in a flowchart type of thing what the anesthesiologist in the operating room has to attend to. And to me, this is daunting, right? There's a lot of stuff going on all at the same time. And if you make a mistake, somebody will get hurt. And it's embarrassing to me as a biomedical engineer that on the patient monitoring side, all what we're giving them to do all this complex stuff is something like this. Basically a random assortment of raw waveforms, hasn't really changed in the last, 30 years or so, maybe with the change, and maybe the only difference is the introduction of colors. My predecessor, Dwayne Westenscope, he had a slide back in the days where he showed how even the order of the waveforms shown have nothing to do with ergonomics or usability, but has something to do with which monitor or which sensor was developed first. It's a historical list. Can't be, right? Okay, so I admit it's not only about raw waveforms, we also extract some numbers. But it doesn't have to be like this, right? The 1980s are calling and they want their monitors back. We know how to do this. Again, it's an ongoing opportunity because about 20 years ago, 25 years ago, our lab, under the leadership of Dwayne Westensco, did some really fantastic work on advanced displays where visually things are related to each other. George Bleich did a study where he tried to create a nice display. And none of this so far has really found its ways into today's patient monitors. We see a little bit of beginnings, right? You can see a little bit of stuff here from Massimo's Radical 7. This is the Alert Watch out of Michigan, University of Michigan, Kevin Tramper's group there. We see a display from Edwards, LBD, and then on the right side, this is a display that LiTCO, lithium dilution cardiac output, the LiTCO people developed. And so we're seeing these beginnings. And I'm not saying these are optimal displays, it's just a new way of relating variables to each other rather than having them all as part of waveforms. And I also want to point out, if we're going into a situation where one anesthesiologist may have to supervise 3, 4, 5, or 6 operating rooms, certainly the old-fashioned displays are not going to cut. Right? If you look at this, it's going to be hard to figure out what's going on with each particular patient, which patient should you be looking for, and maybe a solution, something needs to be explored, maybe. Maybe we can take one of these more advanced graphics and display those as a supervisory type of displays where it's much faster to see where things are heading. So these were some of the trends. These are some of the trends that we looked at and extrapolated. But here's another observation, right? You can see how the innovation curve is kind of flattening out, right? And it seems to me almost as if patient monitoring has become a commodity. Good is good enough. The CFO organizations and the hospitals are buying patient monitors, not necessarily the clinicians. And so we're not seeing that much innovation anymore. And when we know from innovation science that when these curves flatten out, that is a sign that secretly or behind the scenes somewhere, there's a new curve starting, right? That may be a paradigm shift, maybe a disruption to the way we used to do things. And I mentioned earlier that prediction is difficult, especially about the future, but there's another very nice quote that I like, and that is the future is already here, it's just not evenly distributed. It's already here. And so that allows us actually to look into the future. And in medical devices and in patient monitors, it turns out our volumes are relatively small compared to mass market electronics, compared to automotive. And so we have to rely on these standard components. And because of our slow innovation cycles, we can actually see the future, right? We can see stuff that is already out there in the market for us consumers, but we haven't seen those in patient monitors yet. And so from that, we can try and make a few potential predictions. So for example, if I can wave at my smoke detector to make it stop screaming, or if I can wave in front of my paper towel dispenser in almost every public bathroom, why do I still have to push the alarm button, right? Why can't I not wave at my patient monitor and the alarm stops? Especially important maybe in the ICU where I don't want to go from patient to patient and push these alarm off button and maybe cause some infection issues. If I talk to my Alexa in my house, I can control my lights, I can set my heating, I can turn on and off music, I can turn on and off and look at safety cameras. And if that's the case, why can I not talk to the patient monitor? Why can they not talk back? Or if I'm wearing these special ski goggles and I get some environmental and ambient information right up in the heads-up display, or here a Ray-Ban with a second version, a revival of the Google Glass, I think this points to the future of patient monitoring in the sense that maybe we can get our eyes away from those screens, and we don't have to force the anesthesiologist to turn away from the patient just to look at the numbers. Another one where, of course, the mass market and other markets will find their way into patient monitoring is this whole area of big data, or its close cousin AI, which Michael will talk to us about a little bit more. And so I think this is also a very, very important area where patient monitoring will make an impact. And if it's really true that data is the new oil, then our patient monitors in our realm, in our domain, they are really the oil wells, right? And if that's where the wealth is and that's where the value is created, we can treat them better and we can use patient monitors in a better way. And I want to almost close here with this pyramid that I've seen many years ago from Mark and Cermino. I adapted it a little bit. And this is basically how we can think about how big data and AI and analytics can work together in patient monitoring. So it all starts with data, right? Physiological variables. We're measuring clinical observations and maybe even the interventions. We can condense this into information by adding context information. Maybe we prioritize and target it and maybe visualize it in a little bit better way. And then we can condense it even further into knowledge by adding similar cases, common or best practices, maybe estimate the real-time outcome. And the source and the purpose of all of this is not to replace the anesthesiologist, of course, but to free them up so they can actually practice the art of medicine and don't have to do all these menial tasks. And then we can have a great discussion maybe where we are in this pyramid. I think we're about here. So, we have quite a ways to go. And when I give these talks, I usually say that this is actually the future of patient monitoring. And the reason is that this assistant of Dr. Morton was intelligent, he was knowledgeable, he was context aware, he was interactive, you could interact with him in voice or gestures, and he was able maybe even to apply therapies. Thank you so much.